Everybody, I am Emory King with the Detroit Medical Center, and welcome to this web chat. It has been a while since we've had an opportunity to join you, and we are always happy to bring you the exciting news that's going on at the Detroit Medical Center with the incredible expert doctors who work there. Our subject today is on incontinence, the subject of incontinence for men and women. Perhaps you are one who has a leaky bladder or have a loved one who has suffered incontinence. It has affected more than 13 million men and women in the United States. There is I think, no age barrier to this. We'll find out all of that. And people have urinary incontinence issues. A lot of them suffer in silence because they don't want to talk about it, or they're too embarrassed to talk about it, or perhaps they fear that there is no treatment to help them. And there are indeed many, many effective treatments. And so we want to talk about all of that and more today, and we invite you to join us by calling 248-356-0077, 248-356-0077, or of course you can go to WXYZ.com and we will take your questions from online. We are joined today by two wonderful gentlemen who are experts in this field. To my immediate right is Dr. Conrad Maitland. Dr. Maitland is a urologist at the Detroit Medical Center, an assistant clinical professor in urology at Michigan State University College of Medicine, and he is currently the director of urology residency, the urology residency program at DMC Sinai Grace Hospital. He has been successfully treating urological problems for patients for more than 35 years. Nice to have you with us, Dr. Maitland, and it's a pleasure to meet you today. And next to Dr. Maitland, we have Dr. Sergey Marinkovic, who is a urologist also at the Detroit Medical Center. He is fellowship trained in both neurourology, we'll find out what that is, and urogynecology. And he is double board certified in general urology and female pelvic medicine and reconstructive surgery. Over the last several years, Dr. Marinkovic has written many research papers on the subject of incontinence. It's nice to have you with us as well.
Thank you, thank you.
Let me, just by way of quick background, before we launch into this, what is neurourology and what is urogynecology?
Absolutely. Neurourology is actually a science or the study of problems with urination that are related to neurological disorders, similar to patients that have had strokes, multiple sclerosis. Any of these major neurological diseases have in and of themselves their own characteristic problems. So again, those of us that train under this learn how the most up-to-date methods of dealing with these particular problems. Urogynecology is a little bit different, and sometimes they can coexist to a certain degree, but urogynecology is the study again of working with incontinence and prolapse issues, where a female can have a problem with a dropped bladder, dropped rectum, dropped uterus, things of that sort, and then also learning the up-to-date methods for taking care of these issues, both minimally invasively and with the least amount of potential long-term consequences.
Great. Let's begin by getting an understanding of some of the terms and the exact issue that we're dealing with. Dr. Maitland, what is incontinence?
Simply put, incontinence is involuntary loss of urine. For the lay individual who really wants to know that. It can be associated with certain symptoms like urgency. You have the desire to go to the bathroom, but you cannot hold the urine for any prolonged period of time. You lose control. So there's urgency associated with it. There's a frequency where you have to go multiple times, whether it's daytime or nighttime. On the average, we think that an individual should go to the bathroom 6 or 7 times a day. You begin going to the bathroom to empty the bladder greater than 8 times a day, there's a problem. 8 to 10 times a day, there's a problem. So there's urgency associated with it, there's frequency associated with it. And when you go at nighttime, we use a technical term, because it's night, we call it nocturia, but it's frequency at nighttime.
Who is affected by incontinence?
Broad spectrum of patients. Incontinence in women and men is different. The age groups are obviously, because of that, different too. Women, incontinence usually is associated with an injury to the pelvic floor, shortly after childbirth or even years after childbirth in some instances. And then in men, men can develop incontinence generally for two reasons. Either an operation for prostate cancer, where as a sequelae of the operation, they have
Sequelae?
as a result of an operation that they actually are experiencing the loss of urine during various aspects of the day. And then women, again, are slightly different because of the incidence of childbirthing injuries that can, again, manifest at any time during life.
And as men, just let's talk about men for a minute. As men get older and develop an enlarged prostate, which I understand typically happens in men, the prostate starts to grow at a certain age and continues to grow. So that would affect different men, I guess, in different ways. But as men get older, is that necessarily accompanied by incontinence?
If the man has an enlarged gland that is causing obstruction, and it's prolonged and he's not being treated for it, at some point in time during that process, the bladder becomes decompensated. And the bladder becomes so decompensated that they develop the incontinence pretty much like the symptoms. So they have the frequency or the urgency that's associated with incontinence. But the main problem at that time is actually the prostate. Lots of times when you take care of the prostate issue, then these symptoms go away.
They go away.
Yes.
We have Kathy. You're standing by with a question. We'll get to you in a minute. And I have one or two more quick questions for these doctors to set the stage. 248-356-0077 is the number to call. So please join us. Obviously, something can be done to prevent incontinence. Otherwise, you guys wouldn't be in business, right?
That's true.
What do you? And a broad question, I know, but begin to tell us some of the treatments that are available for incontinence today, both in men and in women.
Well, one of the most important things is making the diagnosis, listening to the patient and making the diagnosis. Unfortunately, so many women and men can think that it's a natural result of just aging, which it isn't. I mean, it's not normal for a woman to leak urine. I mean, it shouldn't be thought of as a natural part of aging. It isn't. So that's the first thing, is that for doctors, family doctors, to ask the patient, are you having any issues with incontinence? Because again, the problem with incontinence is that as we get older, it can lead to urinary tract infections and and bad cases of kidney infections and an assortment of other quality of life issues. So the most important thing, I think, is to make the diagnosis when you have an issue, to understand that incontinence is not a natural part of aging, that it should be, if it's a problem for you, something that you could talk to your doctor about.
Was there anything you'd care to add on that?
Well, I mean, he's absolutely correct. There are other issues that people tend not to talk about because it's embarrassing. Mm-hmm. It's a very embarrassing situation. And they believe that I don't want my children or my neighbors or my friend or my caregivers to know that I'm leaking and wet all the time, so they won't talk about it.
Sure.
And by not doing that, it becomes something secretive for them. People become reclusive when this occurs. The young lady who normally sings in the choir on Sunday morning, she's not going to go to church because this is a problem. Right. Sure. They wear dark clothing to protect themselves so that a spot is not available. They go to the shopping malls and they have these tendencies to go to the bathrooms. They know where every bathroom exists in the mall. Sure. They call it bathroom mapping. And these exist, and these are conditions that they need to talk about. As physicians also, not so much as specialists, but as primary care, there's a tendency not to talk about it also.
Right.
So about 80% of physicians don't talk about it, they don't bring up the issue, and the patient won't either.
The physicians don't talk about it?
There are a large amount of physicians who would not bring the topic up.
Why would they not bring the topic up?
For the embarrassing situation, and sometimes they themselves would feel that maybe the age is an issue, and they would miseducation. The whole
miseducation.
Right.
We as physicians may have our certain prejudices. Those are certain things I don't want to talk about.
Yeah.
Like with men with the erectile
Exactly.
Oh, I'm not going to talk about it. I'll talk about your heart problems or these other issues, but I'm not going to talk about
Boy, they
that.
plaster TV with commercials on erectile dysfunction, but you don't want to talk about it.
And
Exactly.
urinary incontinence,
Exactly.
too.
Yeah.
And with
Yeah.
urinary
As well.
incontinence issues, too.
Exactly.
Yeah, absolutely.
Yeah, well, I guess that's a good
So
thing.
that's
though.
how prevalent it is.
Let's. This is Dr. Conrad Maitland, who is a urologist from the Detroit Medical Center, and Dr. Sergey Marinkovich, both urologists, both associated with DMC Sinai Grace Hospital. Kathy, thank you for your patience. Kathy asks, doctors, have MS, retention, and spastic bladder issues. Any ideas without cathing? I'm not sure I understand what you mean with that question, but she goes on to say, and how much urine is too much to retain in your bladder for this problem? Do you gentlemen understand what she's asking in the first part of this question?
Oh, yeah,
MS?
absolutely,
Yeah,
absolutely.
yeah.
MS is, again, a
Be my
neurological issue. MS is multiple sclerosis, and some of the manifestations of the disease are incontinence, where you have that strong desire to urinate. Sometimes you don't have that sensation to urinate, but you leak anyway. And another aspect of that problem, too, is having the inability to urinate. These situations with multiple sclerosis patients can wax and wane. Sometimes you could leak, and then sometimes you don't urinate. And then sometimes it becomes permanent one way or another, that you just have issues with incontinence all the time, or that you do not, you're not able to empty your bladder. So these situations, when they occur, often we hope that these patients and primary care doctors can know that emptying your bladder is important. And that when you don't empty your bladder, or that you are having leakage, that again, make the diagnosis first, or send it to someone that can make the diagnosis. Now, how much urine and all that, I think, is really getting above this area, because again, then we get really kind of technical with how much urine you should have or not produce, or how much you should get when you're cathing and all that. But obviously, when you have the inability to empty your bladder, emptying your bladder is important, because the bladder urine will stop the urine from getting there from the kidneys, and that can eventually lead to damage to the kidneys. And we've already here in Detroit, with his many years here and my many years, have seen patients that have MS or other neurological diseases, don't empty their bladder, and then they have a creatinine function that shows that their kidneys have been damaged, and it's because they're not emptying their bladder. So retention can be very difficult, along with the incontinence issues related to a spastic bladder.
I'm in total agreement with what he has said. And one has to be able to empty the bladder. And sometimes, particularly in an MS patient, the only way that you can get this done is by passing the Foley catheter and getting the water to come out. And you have to do it yourself. It's called catheterization. And I think that's what Kathy is referring to.
Kathy, thank you very much for that question. We're taking questions by email at WXYZ.com, and also by phone. We'd love to hear from you at 248-356-0077. Clarence has sent in an email. Clarence wants to know, how safe and effective is Detrol for urgent urination? That's DETROL for those of you watching.
Detrol is one of the class of medication that comes under the group that we call anticholinergic. They relax the bladder so that if you have urgency or frequency or incontinence, so that the bladder, simply put, becomes larger so that you can hold a larger volume. And it's very effective. It does not necessarily work for everyone, so that the patient it works for and it works well, you keep them on that medication. There are other classes of medication that can be used if you find Detrol does not work for you.
Side effects?
Dry mouth, constipation, major side effects.
Wow. All right, Clarence, thank you for your question. Anne has written in, when I feel like I need to go, I think I'm holding for a few seconds, and by the time I get to the bathroom, I discover I've been leaking all the time and not realizing it. How common is that?
Well, I can tell you that you're describing beautifully urgency, that strong desire to urinate that unfortunately sometimes we can't control and we leak, so you're experiencing both urgency and urgency incontinence. Now, that situation again can be treated, very well by actually learning how to do properly pelvic floor exercises. That's one of the least invasive ways where over a period of 6 weeks you go to a physiotherapist through a doctor's prescription and guidance, and you can learn how to contract the specific muscles that can help your bladder when you get these urges to control itself and give you more time. It also can help with such other things as stress incontinence. And stress incontinence, as opposed to urge incontinence, is when you cough, sneeze, anything that where you tighten your abdominal muscles that you leak. So physiotherapy can be very effective for these problems, along with medication similar to the one that we just recently discussed. So the most important thing is to be aware of it, and when you begin to feel as a patient that, you know, this is a problem for me, and that level is different, or that guideline is different for every patient. There are people that can go through 2 or 3 pads a day and feel that that's fine, I don't need any help, I'm doing well. And then there are people that leak and use a pad every once in a blue moon when they're playing tennis, and they think that it's the end of the world. Everyone is so different. So it's deciding yourself when you think you need a intervention in this problem is extremely important. And that's a different guideline and a different level for every patient out there.
Is physiotherapy as effective for males as it is for females? I assume you're talking about females.
Absolutely. You know, men can actually use it, and maybe Dr. Maitland has treated more men than I have, since I tend to really do more women than men. But his guidance would probably be a little bit more better.
I think it's more effective for the female than it is for the male, because of the reasons that we gave earlier on in terms of incontinence in men. It's usually as a result of a surgical intervention, like radical prostate or pelvic surgery, and physiotherapy works quite well for the female. I want to add something else to Anne. There's something else that she probably can do, is what we consider time voiding. And if she feels that she has to go to the bathroom and she is not getting there in time, and she has accidents, she can probably reduce the time. Go to the bathroom every 2 hours or 3 hours or 4 hours, as the case might be, whether she feels she needs to or not. So she gets her bladder empty so that she would not be there. And then in combination with what Dr. Mishinovich has said, that she can use certain medications that will help. So there are a number of things that can be effective in these treatments.
Pardon me. You know, for the gentlemen who are listening out there, I want you to know that I will represent your interests very well today, because I have absolutely no problem talking about my own condition. I have an enlarged prostate, and I'm under treatment from a DMC urologist, Dr. Richard Santucci, who's a colleague of yours. Mm-hmm. And so as you get older as a man, there's an old joke. And I have a friend actually who has had his prostate removed. We laugh about this all the time, and he's in good shape. Mm-hmm. And when we go out to eat in a restaurant or something, our maxim is, don't pass a bathroom without using it. Right. Take advantage of every time, which is exactly what you're talking about. Right. So that's not necessarily a bad thing.
No, it's not.
You see it, you go.
No, it's not.
What is the mental thing that goes on with? And again, I'm speaking for men, so that's my way of saying, women, call please with your questions. What goes on mentally when you have to go to the bathroom and you feel this increased urgency to void as the bathroom as you get nearer to doing it? Do you know what I'm asking?
I know what you're asking. He might have the answer neurologically, but
well, you know, well, I mean, I don't want to get too complicated here. I want to keep it all straightforward. All right. But you know, your brain really controls everything in your body. Your heart rate, everything you do in this world is controlled by your brain up here. And most of the time, you're not even aware of it. For the most part, your brain will tell a certain part of the lower part of your brainstem when you should go. And unfortunately, sometimes this information, due to other comorbidities, such as patients that have had strokes, since I'm a neurological urologist, patients that have had MS and other various neurological diseases, sometimes this control of the brain to the bladder is impaired. And when it's impaired, that degree of severity is different from patient to patient. So again, the brain does control everything, and often we can be made aware of the need to urinate, and unfortunately, in worst cases, we're not aware. And often that's related to having problems with diabetes or having prior surgeries and an assortment of other concomitant problems that make it much more difficult to control this issue at large.
It was very well explained.
Well, I hope. I'm trying to keep it nice and easy for everybody out here. Not everyone's a nurse or a doctor.
We also hear too, I know there's a psychological component to it.
Oh,
too.
absolutely.
Because you hear someone says, well, I turned the faucet. The faucet
Exactly.
on, and I have to go.
Right.
I walk
Or
by
put the key in the door. Or put the key in the door.
I'm fine all day long, but the key in the door to the bathroom. And
Right.
I'm not sure if that telephone gets that message all the way back and down to the
Sure,
bladder.
sure.
And that's what Dr.
Got
is
it.
talking about.
Got it. The number to call to speak with one of these fine doctors, Dr. Conrad Maitland to my immediate right, and Dr. Sergey Marinkovic, is 248-356-0077. They are part of the fine urology team at DMC Sinai Grace Hospital. We would love to talk to you and take your questions. Or if you'd care to ask your question by email, it's WXYZ.com, and you go there and you'll be directed to this live web chat. Can anything be done to prevent incontinence?
That's a very good question.
Yes, it is.
Incontinence, let's talk about like women in general, things that you can use to prevent incontinence. In Europe, a lot of children are taught in first, second, third grade. When I trained in England, it was amazing how children are taught how to do pelvic floor exercises, how to tighten their, bladder, etc. And we don't do that here. I mean, we would probably consider it abnormal to teach a first grader or second grader or third grader. But in Europe, it's quite common. So these patients will have a better developed pelvic floor and control of their pelvic floor. I mean, if you want to prevent, urinary incontinence, one of the things you can do is actually just pay attention to your pelvic floor and try to develop your pelvic floor. And then with that, other preventive measures are again, for urgency problems, is watch what your trigger factors are. There are some times, most times, that patients will say, you know what, I cannot drink coffee anymore. I mean, many different milk, certain foods, tomato-based foods, and all these other little things that potentially can be irritants to the bladder. So, and they find, you know what, doc, and then, you tell them, well, you're taking 10 cups of coffee a day, try to cut it down to 2 or 3, and then see what the changes are. And then these are little things that you can manipulate. I mean, you can go on the internet and look at diets for incontinence, and then it'll explain to you the triggering factors with foods, activities that we do, and other means that you can non-invasively start to get a hold of this by yourself.
Sure.
And it's pretty easy, and it's still fairly effective. And then maybe when those situations don't give you a good result, that you proceed on with discussing this with your family doctor.
Cool. Georgine has written in. Georgine asks, my physician ignored my pleas for years. Another doctor, who is a specialist, has prescribed, help me with this, oxybutynin?
Oxybutynin.
ER 10 milligrams. It worked for a week or two. Now it seems to have quit working. Can the drug be increased? First of all, why don't you tell us a little bit about oxybutynin?
Oxybutynin is another of that medication, the same class.
Yes.
Anticholinergic. Stretch, relax the bladder so that it increases the capacity, simply put. And the answer is yes. It can be increased. But it depends on whether you use it. And again, we get into discussion that may be off-label, but it can be. And apparently this young lady is seeing a specialist, and I'm sure he can talk to her, and they can have a discussion in terms of what he can do.
My one thing is that, she's been starting, that's pretty much a starting dose for that medication.
Yeah.
That is not the end of the road. That is not like, okay, this has stopped working. Well, it has stopped working, but there's actually 15 milligrams, 20 milligrams, and 30 milligrams that can be utilized.
Yes.
So many times patients will see a doctor and they'll say, well, they put me on oxybutynin, and then I was so upset that 4 weeks later I was still in the same situation that I was before I saw him, so I didn't see him again. Well, there's the mistake, because you didn't
You
go
see.
back.
Yeah, exactly.
The opportunity to increase that dose wasn't given to that gentleman. And then the patient feels like a total failure. And then they lose confidence in their doctor and then proceed to go on with this problem silently.
So you got to monitor this regularly.
Absolutely.
Absolutely.
But the patient has a
Know this problem.
responsibility to follow up. You know?
This is
Right.
maintenance therapy.
Yes.
This is not like you take
That's
these
not the
pills
cure.
for 4 weeks and you're cured. No, not by any means. This is maintenance therapy. This is something that when you have an issue and you start medication and it's working for you, you need to continue the medication. Discontinuation of the medication will lead to progressing back to where you were.
Do these medications generally get to a point, though, in reference to Georgine's question, where they become
Tolerance.
ineffective?
Yes.
Yeah, you can
You
develop
can get
tolerance.
to the medication.
Yep.
And they don't work.
What do you do then? Go to another medication?
Or add another one. You can have combination therapy. You can switch. You can increase the dose. There's so many different things that you can do.
There are 8 currently medications of this type that
Yeah.
can be utilized that are fully licensed by the FDA for use for an unstable bladder. And, you know, we have a choice of 8, and there are various different doses for each and every one of those medications.
So again, it may be comforting for people to know that because you have an incontinence issue, it doesn't necessarily mean that that is going to lead to some surgical procedure to correct it.
Not necessarily.
Correct.
You're absolutely correct.
Absolutely.
And is there any data that indicates the percentage of people, of these 13 million people, and maybe you don't have this, men and women who have incontinence, how many of those people are able to live a quality of life medicated as opposed to having to have a procedure?
Well, enough of them are not being treated. Only about 13% of patients with incontinence, of the
What per-
13%.
13% of the 13
That's
million.
Yes,
why making the
that get treated.
diagnosis
Oh my God.
is so
That is-
important.
is
Making the
important.
diagnosis to start everything.
Yes.
Sure.
And it's really up to the patient to say, you know, I have a problem. I understand there's a way to get help for this. Let me start with my family doctor.
That's right.
Sure.
Help
Let me
is
give them a call.
available.
Help
It's
is available.
available.
That's the most important thing. The big takeaway point.
And these are 2 excellent gentlemen who can help you with the problem. And for those of you who may just be joining us, and we have a couple of phone calls to get to in a second. My name is Emory King with the Detroit Medical Center. I am joined by Dr. Conrad Maitland to my immediate right, and next to him, Dr. Sergey Marinkovic. They are part of the urology team at the Detroit Medical Center's DMC Sinai Grace Hospital. We are talking about the subject of incontinence in men and women, as you just heard us say. 13 million of you here in the United States, young and old, have urinary incontinence issues. And many suffer in silence because, quite frankly, we're just too embarrassed to talk about it. Well, you don't have to be embarrassed because there is treatment. And in fact, it is indeed very important that we talk about this issue. We're going to go to the phone lines now, 248-356-0077 or WXYZ.com. And we want to go to line 1. And I believe we have Catherine there. Do we not? Catherine?
Yes.
Hi.
The reason I'm calling is I was telling her that I went about 6 months ago to my doctor for incontinence, and she prescribed this medication for me, and it gave me a urinary tract infection. I'm 74 years old. I've never had a urinary tract infection ever, and I keep getting it over and over and over. And I've been taking like baking soda and water to get rid of them, and I wonder what I still have my incontinence, and I don't know what to do about it because I'm afraid to take any of those medications, you know, that you prescribe. Because I asked the pharmacist, and she said, yeah, they'll cause it. So is there anything I can do besides exercise or something?
Well, you know, Catherine, I think what's really important is to also explain why you were potentially getting these urinary tract infections all of a sudden with your incontinence. You know, if you look at my hand being the bladder, and then my finger being your urethra, you could see that when you have incontinence, the urethra can be wet, meaning that in men and women generally that have no urinary tract infections, their urethra doesn't contain any urine unless you're peeing. So when you begin to have problems with incontinence, that urethra has some, you know, a few droplets of water, so that communication of bacteria from your vagina and from your rectum can actually be readily made to the urethra, and then much more easily that infection can be carried to the bladder. So often patients like yourself that have incontinence due to urgency or to stress incontinence, again, seeing probably in your case, seeing a specialist would probably be better able to define what the situation is. Now, as a segue with this, another important point that I teach all my residents is that, you know, patients that often have incontinence and urinary tract infections, okay, incontinence and urinary tract infections. So many have issues with constipation.
No,
You
I'm
know,
not.
women have the rectum and then they have the vagina literally this close, and the urethra is right here. So that with constipation, the colony counts of bacteria that cause urinary tract infections, because just about every bug that we see with urinary cultures comes back, originates from the colon. So that women with constipation issues, where they're not having a daily bowel movement and they're having urinary tract infections.
That's not me. I have diarrhea. I've never been constipated in my
Okay,
life.
yeah, but it's just one little teaching point for the group
Yeah.
of patients out there that are
Right.
listening, because so many women have this problem. So if you take care of the constipation, the bacteria count goes down, and then the urinary tract infections go
But I
away.
have diarrhea. Would that pertain to the same thing?
Well, you know, potentially. I mean, if you're
I
having...
mean, not diarrhea, but I go every day, you know. I
Okay.
go 4 times a day.
Yeah. Well, most likely then, with you, it may be related to just having a urethra that is wet, what we in our field call a wet urethra. So
Right.
that can communicate very easily from the tip of the urethra all the way to the bladder, because a woman's urethra is only about an inch long. A man's urethra is about 9 to 10 inches long in some cases. So a woman has only that much protection from the vagina and outside her body to get to her bladder.
Catherine, thank you very much for your call, and we certainly hope it
I also
helped.
wanted to tell you, I drink a lot of cranberry juice. Do you think that really helps too?
You know, cranberry juice is a great point to bring about with urinary tract infections. My only thing is that if you're a diabetic,
Oh,
to
no.
not use cranberry juice.
Okay, I drink, that's all I drink now is cranberry juice, and I take the cranberry for urinary tract infections. It does help. The minute I get one, like, say I get it Sunday morning, by the time Sunday night, it's gone, because I fill myself with water, cranberry juice, baking soda and water, a little bit, not a lot, you know.
Well, Catherine, actually, those points that you just brought up are valid and have been in
Okay.
use for decades, literally, and a lot of doctors know.
Old-time remedy, right?
Yeah, exactly, and a lot of them do work. But the most important thing for patients out there in the audience is that if you're a diabetic, don't use cranberry juice. Cranberry juice has so much sugar that it will raise your blood sugar, and then you have a lot more sugar in your urine, and that will lead to more urinary tract infections.
Yeah.
So that's a big
thank
teaching
God I'm
point.
not, you know, I know this comes with age too.
Mm-hmm.
You know, I know my body's old and it's falling apart. So I
Oh,
know
don't think that way, Catherine. Come on, you know. I'm not that much younger than you. We ain't falling apart, Catherine. Catherine, I'm going to move on. We have some other folks online, but if you'd like to speak with these gentlemen anymore, you can contact them at 800 DMC 2500. All right?
Okay, thank you.
All right. Thank you very
Bye-bye,
much.
Catherine.
Thanks very much for your call. I'm hopeful that Sophia is with me now. Sophia, are you there? Hello? Okay. Apparently we've lost Sophia on line 2. We do have an email from Marianne who says, what do I do for a prolapsed bladder? And I'll ask you to begin your answer by defining a prolapsed bladder. I've heard that the mesh and sling are not good to do, nor do they last. What's a prolapsed bladder?
A prolapse bladder is a bladder that has fallen down. It's in our line of work, we say that the bladder has lost its domain where it normally belongs. It's lost, it's fallen down.
What makes
and
it
for
fall?
several reasons. Patient may have had a hysterectomy. Patient may have had childbirth trauma. Some of the things that were mentioned earlier on. Those are the most common reasons that will cause the bladder to lose its domain.
Right.
And when that happens, there are a number of ways in which the bladder can be fixed. And you can bring the bladder back to its domain, bring it back to its location. Her issue, I think she's driving at, is the mesh issue. Well, I don't know that we have enough time to talk about meshes here today.
Well, you know,
No.
mesh is a big issue, obviously, because now on TV you'll see advertisements for, have you had a mesh implant for a
Call
drop
it.
bladder
Oh, yes, yes.
or for a sling, and if you have a problem, give us a call,
Yes.
etc. And these are attorneys that are, you know, trying to find these patients that have had these issues with mesh erosion. Now, mesh in and of itself is a synthetic product that's often been used to help support the bladder, rectum, uterus, or the very top of the vagina after a hysterectomy, which we refer to as a vault. Now, mesh again has been used for, you know, since the 60s for a good 50 years with very good success. General surgeons use mesh for hernias all day long with great success. Now, unfortunately, what I think is most likely occurred, and Dr. Maitland may agree with me, I think a lot of the mesh issues are operator dependent,
Yes, it is.
surgeon dependent. A lot of inexperienced surgeons were putting mesh in patients back in the 90s and, you know, in the early 2000s. And then this mesh not being placed in the proper plane, not properly fixated or fixated too tight or too loose or what have you, can lead to severe issues. And we all that do this kind of repair work see it every day. So mesh can be a problem if placed by inexperienced surgeons. So
Does it last?
It can last. I've been doing sacrocolpopexies for a good 15 years, and I keep in contact with these patients, or they email me, et cetera, and my patients that have been out 15, 16 years now are still doing well
Right.
with minimal amount of complications. But again, this is something that I do all day long, and this is all that I see. I don't deal with many other things outside of prolapse and incontinence issues. So, and my expertise is, again, that I've been fellowship trained, and I've seen this done every which way possible, and have chosen the best way that I feel with my hands can affect a good cure. So mesh, again, can be a problem in the wrong hands, but with expertise, with people that are very well established in the community and at their medical center,
Right.
that are well thought of in the community, again, those
Right.
patients are who you want, those physicians are whom you want
So
operating on you.
translation on that is go to this guy, all right? Now, let me ask this guy. Let me ask this guy about the sling. Is the sling good to do? Does it last?
This thing lasts, yes. Particularly for the male,
Yeah.
it works very well. It works very well for the female also. You have male slings and you have female slings, particularly a male who's had prostate surgery and he's incontinent. We have a number of them that we placed male slings in.
And the
And
sling, I'm judging from the sound of it, that it
It's
just
like-
lifts the
it's
bladder
like
and
a
holds it
hammer.
in place.
Yes,
like a
it
hammer.
holds the bladder in place.
Well, I mean, if you look at your hand, again, my analogy of my hand
Yes.
being the bladder and then my finger being the urethra, what it is a piece of material that's placed to support either the bladder neck, that's called a pubovaginal sling in a woman, or in the mid-urethra, which is what's the most common operation now for incontinence, where it's placed in the middle of the urethra. It's a mid-urethral sling.
Yeah.
So what it does is support when you cough and sneeze, the sling moves up and closes the urethra so that no urine comes out.
You don't leak.
Okay, thanks, gentlemen. We're going to go back to line one. Sophia is back with us. Sophia, are you there?
Sophia. Yes.
Sophia, thank you. What's your question?
Yes, I have incontinence. I've gotten somewhat better, but it's for a while, about 5-6 years, and I was using like 45 Depends a day, but then I started taking like 4,000 units of vitamin D twice a day, and within a week's time, it just checked like I never had it. But you know, if I don't take my vitamin D, I might see that I might in a couple of days I have to still maybe run to the bathroom, but I don't have to go back on my Depends. But as long as I take my vitamin D, so I'm wondering, is that something that a doctor would recommend, or is vitamin D, does it do that for the body, or what?
You know, that's a great question, but I can tell you one thing. My concern with using vitamin D, it's a fat-soluble vitamin, and it can really accumulate in your body and become toxic. Now, how many pills is that for 45,000 units?
No,
4,000.
Oh, 4,000. I'm sorry.
IU
Once a day?
Twice a day.
Twice.
And you say it
So it's
can
8,000
become
units.
toxic?
Well, it potentially can be. Vitamin D, like I said, is a fat-soluble vitamin, and the toxicities, I believe, include neuropathies, where you can get pain in your legs and your extremities because of irritation of the nerves. And also, you know, it has other worse scenarios than that. But those are things that you got to watch with that. Now, vitamin D in and of itself being used to treat incontinence, I'm not aware of anything.
I'm not
that's
aware
ever,
of it either. I'm not sure what the
Yeah,
vitamin D
I
is
take
doing.
exactly vitamin D, so I don't know if that makes a difference because it's supposed to be those are food supplements or versus just any vitamin D. Now, I'm not going to
But
say
Sophia,
what-
this is Dr. Maitland. Have you ever seen a specialist about your bladder?
No.
Well, I think
I
that's
talked
something
to
you
my
should think
doctor
of, you
about
know?
it a couple times,
Uh-huh.
and he gave me a prescription, but it was too expensive. It was $70-some.
Well, you can
And,
take it one step further and go to a specialist.
What's
Call
that?
the DMC hotline and come to see Dr. Mashevitz, who probably knows about it, or you can come to see me or any of the other urologists. And if
Okay.
nothing else, you would have a robust discussion about what's happening with the bladder. And then,
I was wondering, that's why I really was wondering, am I doing myself harm by doing that? You know, if I'm taking, it's really 8,000 units, international units IU per day, taking 4 in the morning and 4 in the evening, and whether I am, you know.
I have not seen anything in the literature anywhere that tells us that vitamin D
correct. I agree with
works
them.
on the bladder.
Yeah.
I mean, the problem in it itself with incontinence, if it's related to stress incontinence or both, it's not really vitamin related.
No.
I mean, it's a connective tissue issue in general where your tissue in general has been weakened in certain areas of the body that can lead to incontinence or a dropped bladder or, like I said, a dropped rectum, and et cetera. So it's really more of a connective tissue that vitamin D, like I said before, probably is not directly responsible. It might be other things. Maybe you're drinking less or doing something that at that same time or since that incident for you that has now changed that result for you. But it's probably not related to vitamin D in and of itself.
Okay, Sophia, Sophia, I'm sorry,
Sylvia,
Sophia, I'm very sorry. Thanks,
Okay, that's
thanks
okay.
and good
All
luck.
right,
and,
but I will check
what-
my doctor because that's why I was wondering am I doing the wrong thing? You know, I don't know.
One more thing, Sophia.
Okay.
1-800-DMC-2500 and ask for Dr. Maitland or Dr. Marinkovic. They'll be happy to
call
talk
what
to
now?
you. 1-800-DMC
Okay.
2500.
Okay.
And
Thank you.
the names are Doctors Marinkovic and Dr.
Marinkovic?
And Dr. Maitland. Maitland, M-A-I-T-L-A-N-D. Maitland
Okay.
and Marinkovic.
Okay.
All right? Good luck.
All right. Thank you.
Thank you so much.
Sure. Bye-bye.
All right, Patricia is asking. Patricia has a husband who had prostate surgery several years ago. He has a leakage. He does not like to wear pads. Is there any medication or treatment available for him, Dr. Maitland?
There is treatment available for him. I'm not sure there's certain medicines that can be tried, a class of anticholinergic, but if his incontinence is really related directly to his surgery, and I'm not sure what type of surgery he may have had. It could be just scraping of the prostate, or it could or it could be a radical prostatectomy. Then he really needs to sit and talk with a urologist and have an evaluation. And then after this is done, then we know exactly what type of treatment is necessary for him.
Great. Anything to add on that, Doctor?
No, I agree 100%.
All right.
Like I said, the type of surgery, and most likely, if he's had a prostate surgery, he could have stress incontinence. Like I said, stress incontinence is when you cough, sneeze, increase your abdominal pressure, that you leak urine, and then urgency or urge incontinence is when you get that sudden desire to go and you just can't get there and you leak. So he may have both. And one is more a surgical problem, while the other one could be treated more with medicines.
Got it.
So that's something to be thought of too. So try to think about it. Honey, is it when you get up out of a chair and you tighten your muscles, or when you cough that you're leaking, or is it that you just can't get to the toilet, unfortunately, in time? Or both. And then if you have both, it's a little bit worse, obviously.
All right, that is Dr. Sergey Marinkovic. This is Dr. Conrad Maitland. They are DMC urologists at Sinai Grace Hospital. Call us at 248-356-0077, 248-356-0077, or WXYZ.com, and I'm sure you'll see that number there. We'll take your email, We'll take your calls. We are talking about the subject of incontinence and anything related to it. We have a question from Joanne by email. Does help me with this one, docs?
Hyponatremia, low sodium.
Low
in
sodium,
blood.
hyponatremia add to incontinence? Have at it. Who wants that one?
That's a great question.
I don't know.
I wonder if this is a doctor
Joanne,
trying
you
to stump
stumped
us.
Yeah,
Dr. Joanne, got you, right? You bet.
Yeah, exactly. Great job. Great job. You did get us.
Well, with hyponatremia,
I mean, hyponatremia is low sodium,
right.
in your blood. And that can happen for a multitude of reasons. Low sodium
you treat it with the diuresis, so you give Lasix.
yeah, you
So
can
then
treat a
you
lot.
get less
Way above my head.
Let's explain all
Let's
that.
explain that. Okay, so you want to get the sodium concentrated. It's too low.
Yes.
So you want to get it concentrated in the bloodstream. So you give a certain medication that would get you to give off more fluid, more
yes.
water.
To get you to pee.
To get you to pee more.
Right.
So the
So that could be the
peeing
incontinence because it's so much.
could be the incontinence.
Ah.
So that would probably, it's not really a true incontinence.
Got it.
But
It's induced.
it's a treatment that's induced because of medication. And that's another issue with incontinence. There are some people who may present and say, well, I'm incontinent, but they're taking Lasix, water pills for congestive heart failure or high blood pressure or
And
anything
incontinence
else.
is the result.
Is the result.
Joanne, you have to get up pretty early in the morning
To think
pull
about
one
this.
over on these guys.
And you, and,
They came through.
and you spelled hyponatremia correctly, by
Yes.
the way, which is pretty good.
Which is probably an indication that she is a doctor trying to say.
But she spelled incontinence incorrectly.
She did spell incontinence. It was a good catch. Good catch. Dr. Maitland, Dr. Marinkovic, it's great to have you with us today. We're talking about incontinence today. We're taking your emails and calls. Genevieve, and apparently there are a lot of them today. When I have a cold, Genevieve says, and I cough, I lose control of my bladder, which is that stress incontinence
Yes,
you were talking
absolutely.
about again.
Absolutely.
Other than using the pen pads, is there a solution to this problem?
You know, dear, when stress incontinence becomes an issue, I'm one of the school that, you know, if you do the physiotherapy to tighten your, your pelvic floor,
Muscles.
if you have the resources to do that, if you have the time, because again, this requires you to not only do the 6 weeks of an introduction where you learn how to tighten your muscles, contract them, make them stronger to get your effect, you also got to remember that from the moment on, you have to continue it afterwards in order to still remain with good control of your bladder and with an improvement in your urinary symptoms. So if you stop, you do the 6 weeks of exercises, learn to do it, get a good result, and then you say, well, I don't want to tighten my muscles once or twice a day. I don't want to do that. Forget about it. It will just, your symptoms will return. So with stress incontinence, often with people, I'll make that judgment. I'll tell them, look, I can send you to physiotherapy. You can learn and probably get better, you know, as long as their symptoms aren't too overwhelming. But once you get above 2 or 3 pads a day, I usually recommend surgery. And now surgery, minimally invasive surgery in our hands with people that just do it all day long, is, you know, a 15-minute operation, same day, and you go home literally without a catheter, you know, most of the times. So, I mean, often stress incontinence, if it's that severe that with a cough, or if it becomes more frequent and you know that you need to use pads every day, stress incontinence, in my opinion, for people that aren't really 100% motivated to do physiotherapy, surgery can be a quick fix and can be a long-term fix as long as you pick the right people to operate on you.
All righty.
I agree.
Fine staff over at Sinai Grace provided this set of questions here, which is kind of interesting to me. Common myths about incontinence that we might want to address. Let me just, while we're waiting on our next call, just
Natural part of
run
aging.
through one of these. It's part
That's
of
the big
it's
one.
part of
That's
a normal
always the
aging,
big
or
one.
you know I'm in
That's
advance.
always
All
the
right.
big
Is
one.
incontinence a part of normal aging or everyday life?
No, it is not. Often incontinence is a sign that you've had some sort of trauma to your pelvic floor in a woman or in a man for that matter due to prior prostate surgeries, and that this has led to your issue. So to think that it's just a natural part of aging, no, it generally isn't.
I'm a guy that I do these. I'm the voice of the DMC, and so how many of these radio spots have I done where I've given out the number DMC 888 DMC 2500, and I've been giving you the wrong number. The deal's probably off now with the good folks in the DMC. The number is 888-DMC-2500. So for those of you who wrote down 800-DMC-2500, shoot me. 888-DMC-2500 to get in touch with these gentlemen, make an appointment, or find out about anything going on at the DMC. 888-DMC-2500. Let's go to line 1. And on line 1, we have Lavinia on the line. Hi, Lavinia.
Hi.
Hi, what's your question?
Nighttime leaks and a substantial undergarment that is just impossible to find.
Did you
No, I didn't.
I didn't get
Can you
it.
repeat the first part?
Are you still there?
Yes, I'm still here.
Are you still? Would you repeat the question, please?
What can I do about nighttime leaks?
Oh, nighttime.
Nighttime.
leaks.
Nighttime.
Got
Okay.
it.
Well, I can tell you that, again, there could be several different reasons why you leak at night. I mean, during the day, you're pretty good.
I'm pretty good, except all of a sudden you have to go to the bathroom. You should have been there a minute or two ago.
Okay. Now, are you on any kind of water pill or anything like that?
Well, water pill, yes, whatever that is from you.
When do you take it?
In the morning.
In the morning. Okay, so it should be out of your system by the time you go to bed. Now,
Yeah.
nighttime urination, again, can be a situation where you're, again, having an unstable bladder. Are you aware of the leaking episodes? Does it wake you up and you just can't get to the toilet quick enough? Or is it
Okay,
that you wake up and you're wet?
Well, I wake up and I'm wet, and I don't know when it happened or why it happened.
Ah, okay. That could be a very severe... How long has this problem been going on?
Oh, for a while.
Have you had it since childhood?
No, not since childhood. It just happened as I aged. I'm almost 71 next month.
Well, it's how old?
I will be
71.
71.
Oh,
next
71.
month.
71.
It could be again an overactive bladder.
I'm thinking that. So what does one do about that?
Again, as we've been talking about, some of the minimally invasive things you can do is do the physiotherapy, and then if physiotherapy doesn't really work, you can start on medications that can be used to help you get control. And again, medications come at different doses, so whatever dose you're started on, for the most part, won't be the only means of getting an improvement, because the medication dose on all these medications can be increased for the most part.
Okay, well, I'm probably on the need medication stage. Okay, now I have tried the Kegel exercises or whatever, the Kegel or whatever they are.
Yeah, that's it. That's part of the system. Yeah, absolutely. Well, that's unfortunate because Kegel is a great thing. If it works for you and you're motivated to continue doing it, that's wonderful. But if again, that's not the end of the road. If things don't work out for you with that, medication is available, and there are 8 different types of medication, and many of them are generic too. So economically, there are different ways that we can solve this problem for most
Okay,
patients.
there are 8 medications.
8 medications out there, and about 4 of them have generics available.
Okay.
Lavinia?
I'm almost certain that I need probably the stronger medication because hey, I've been dealing with this really.
Well, you
Like
need to
I
be
said,
evaluated.
Yes,
Again,
you
like
need
I
to,
say,
yes.
we need to make the diagnosis. We got to find out exactly
What the
why,
problem is.
and then we can deal with it.
Important to see a specialist,
That's
Lavinia.
right.
Good luck with this, okay?
All right,
Thank you very much for your call, Lavinia.
A urologist?
Oh, absolutely.
Okay, thank you.
All right. And the number to reach them, by the way, is 888-DMC-2500. Call 888-DMC-2500. We have a few minutes and more calls that we can get in, and we're going to go to line 2. Crystal. Are you there, Crystal?
Yes.
Thanks for joining us. What's your question?
My question is, do you get stress incontinence from obesity or from having too many babies?
Do you get what kind of incontinence, dear?
Well, if I put stress on my body,
Stress.
like try to stand up from a seated position or a lying down position,
Stress incontinence.
yes.
Stress incontinence right there. Obesity in and of itself, it's because the tissue in obesity is, your tissue is weaker. The heavier we get, the weaker our tissue is. Everybody says, well, I'm big. Well, it's not so much how wide something is for leakage pressure, it's how tall someone is. I always teach this to my residents. It's probably not as important for the general public, but again, being obese in and of itself is not a reason for incontinence, but it's because of your weak tissue. Now, what was the other thing that you mentioned that you have?
Trauma, birth trauma.
Oh, birth trauma. Yeah, that's
Yes,
the number one
no
cause.
question.
Number one cause. Number one cause. Absolutely.
The number one cause is picking up heavy things or
That too.
That
That
too.
too. Right
Yes.
there. Absolutely, dear. You're giving us a great classic example of trauma to the pelvic floor that can lead to most likely mixed incontinence. Now, mixed incontinence we haven't really touched on by term, but mixed incontinence is when you have stress incontinence, anything that creases your abdominal muscles and you leak at that time, and urgency incontinence. And urgency incontinence is, again, the sudden strong desire to urinate that you lose control over and you leak. Mixed incontinence, again, is a situation where you have a combination of both. And that's more common once we get above the age of, say, about 55. Once we get above 55, most women, not most women, but, probably 50%. Yeah. Usually between the ages of 40 and 60, it's stress incontinence, or 40 and 55, and then once you get above 55, it's both methods of incontinence that seem to be at work for most
Well, how
patients.
come I had it when I was carrying my baby?
Even if you had your babies when you were in the 30s and 40s, it would take years later on for it sometimes to manifest itself.
Sometimes it's immediate even.
It's immediate
I've had
sometimes.
women that
In
leak,
their 30s.
right, that give birth, and then since giving birth are leaking. And then there are women that it's 20 years later. I mean, the pelvic trauma is different on every person, every
Well, it's
patient.
not just from having too many babies.
Well, it's not too many.
Um,
Generally, it's associated.
And getting too old.
Well, it's generally associated, believe it or not, with the weight of your child at birth. If the child, you increase your chances of developing incontinence if the child is 8 pounds or more at birth. Or if you've had birth 3 or more times, given birth 3 or more times.
Or if the baby was turned in the wrong direction and you had to rotate the baby.
Exactly.
You know,
those are all
those are
things
all
that
factors that are
exponentially
important.
increase.
Well, I didn't have any breech births, but
Or if they used forceps too to
deliver.
help to deliver the child. Yep.
Crystal, we're going to thank you for your call. We're running out of time, but good luck with that, and feel free to contact these doctors with more questions, okay?
all right, thank you.
Crystal, thank
My
you
pleasure.
very much. And speaking of contacting these doctors and others with your questions, the Detroit Medical Center, DMC Sinai Grace Hospital, will host a free educational class on incontinence in early 2015. So to take part in this free incontinence class at Sinai Grace Hospital, call this number, 888 DMC 2500, to receive an invitation. So this is my invitation. But that's a pretty good thing to do. So you'll have an opportunity, and I would take it you gentlemen will be involved in this.
Yes.
And people can come and just exhaust their questions with you and perhaps other members, other colleagues.
It's our pleasure. It's our
At
pleasure.
that night. So you want to stay in touch with at dmc.org/urology, and I'm sure there will be some information posted there. And again, you can call that number that I keep repeating, 888-DMC-2500, and ask for Dr. Conrad Maitland or Dr. Sergey Marinkovic, both in the urology, urologists at the Detroit Medical Center. Dr. Marinkovic, again, an assistant clinical professor of urology at MSU College of Medicine, currently the director of the urology residency program at Sinai Grace. And that's Dr. Maitland, I'm sorry. Dr. Marinkovic is fellowship trained in, as we talked about earlier, neurourology and urogynecology. So he's double board certified. These gentlemen are experts, and your answers to these questions have been incredible. And let me compliment you, because you speak to laymen very, very well and explain these
Thank
very
you.
complicated issues in a
Thank
way
you.
that is very,
Thank you.
very understandable. Are we about out of time, Seth, or can we prattle on with some more questions? I think we've pretty much done it. Doctors, I don't know how to thank you for your time.
Thank you.
Well, thank you. It's
thank
been
you.
our pleasure.
It's been a
The
pleasure.
pleasure is always ours, and we,
Yeah,
of course,
thank you.
Been great.
It's been wonderful. It's been a
Yeah.
blast.
we of
Yes.
course thank the wonderful people here at WXYZ-TV, the finest television station and news department in the metropolitan Detroit area. We really, really appreciate this relationship. It's great to be involved here. It's great to be involved with you. Again, 888-DMC-2500. Contact us. We'd love to help you. Thank you very much. I'm Emery King. We appreciate your joining us. Have a great day. Bye-bye.
Bye-bye.